I think we're ready to get started. We do have a person back there in the corner videotaping our every move, so smile pretty if you see that camera, if you look in that direction. I'm not going to say too much because Pete Farrell from Group Health is here to do a full presentation on a second option for our insurance plans. And so what I'd like to do is start out by having everybody from Group Health at least introduce themselves to this group, and then you can take off.
We can just run them around the room. Sarah, you want to start?
Sure. I'm Sarah Kalasa. I'm one of the health promotion coaches at Group Health.
Beth, you're next.
That includes me.
Yeah, it
Yes.
does.
I'm Andrew Pfeffer, I'm in marketing. Luke Johnson, Chief Financial Officer.
I'm Dr. Bauer, I'm the Chief Medical Officer.
Kay McHugh, I'm the underwriting and sales manager.
Crystal Cannon, sales.
Alyssa.
Alyssa Hofer, clinical pharmacy manager at Pharmacy Star. We have AJ with us, she's our pharmacy student.
AJ's here. Like I said, we're half the room. So my turn now?
It is.
Okay. Part of the reason we got a whole bunch of people here is so not only do they hear the kind of just what I'm talking about in the interaction, but also the questions you have as we walk through kind of a new product. And I like to have as many people as possible hear the questions that you guys have, the concerns you have, just kind of get a feel for it. So if you have questions afterwards, feel free to ask any of us, and we'll get the best answers for you can. We also have Dr. Jody Rich from, I haven't seen you in like a week. It's a long time. Dr. Rich is part of the new clinic that we've helped put together to kind of create this alternative for you. So I'm just going to walk through first just a handful of things. A brief history of the Cooperative, just to give you our perspective a little bit. We are different than other insurance companies. We're one of two organizations in the state that's technically not a health insurance company, but we sell health insurance. We're organized as a co-op, just like a farm co-op or Mega or any one of those. The biggest difference between us and the insurance companies, we have to comply with all the statutes that they have to. The biggest difference is our governance. Our board of directors is made up of our members, and other insurance companies don't have that. In fact, they have completely different governance requirements. Mary has been our board president for, I don't even know. Yeah, we'll call it 6 or 7 years. How's that? Does that sound about right? That sounds somewhere in there. Under my 20-year tenure, Mary is, I think, our 4th board president. So. But and we are introducing this product to 3 of our longest tenured groups, the city of Eau Claire, our employees, because I want our employees to kind of go through every new product and things, kind of familiar with everything that we're doing, and Huebsch, and I'll explain why in a bit. But Huebsch has been covered by the Cooperative since 1978 or 9, right? Well, we started in January of 78. That's when we started providing coverage, so December of 77. So that's a long time, since before many of you were born. And so we certainly appreciate the membership. We appreciate you being part of what we do at the Cooperative, and it is important to us. I talk about our purpose statement all the time, optimizing the health of our members, because we really focus on that, and it's a fundamental part of what we do. It's why we push to develop kind of the things that we're talking about today, and our values, especially that first one that talks about, engaging our members to create solutions. The whole presentation, everything we discussed today, is a great example of that, because we've worked a lot with kind of the feedback that we've gotten from our members, talking to them, getting kind of input, getting concerns and things like that, as we try and do something about what we know is the challenge. Healthcare costs are going up a lot faster than, well, everything else except school costs, and much faster than the rate of inflation, eating up too many other costs for employers and for all you guys, and so anything we can do to impact those costs. We've tried a number of different programs through the years. Our health promotion program, which everybody loves, Sarah, one of our health promotion coaches, is it's an important program for what it accomplishes, and for the groups that we have that have a very active health promotion program, it helps control costs at about half the rate of increase as the rest of our groups. Most of our groups in our commercial block average about a 7 to 8% increase over time. And the groups that have active wellness programs average about 3%, 3.5%, which is pretty consistent with where things are nationally in programs like that. But we have our coaches that do a very active role working with our members and kind of talking about various healthy lifestyle activities and things like that, and not just weight issues and things like that, but also blood pressure management, cholesterol management, getting preventive checks on time and things like that. So a lot of interesting stuff. Our telemedicine options with Teladoc, the ability to call a doctor on the phone rather than having to go into urgent care and things like that, that's had a pretty good impact. We have higher than typical utilization for that. More of our members call than a lot of groups experience. So that's a good thing. And our destination medicine program, the ability to get a surgery somewhere out of the country or in another part of the country where it's significantly less expensive, and or get a colonoscopy somewhere else. I had a colonoscopy done a few years ago when we first started the program. I was our first guinea pig, for lack of a better term. I said I would go first. Everybody, when I volunteered, when I said we're setting this program up in like June of 2016, everybody thought, wow, he's stepping up. And then they realized that meant in January of 2017, I was going to go to the Cayman Islands for a long weekend. Like, suddenly it didn't seem like I was taking, a real hit for the team. But it's a great program. It either gets you for a colonoscopy, it gets you to a great location if you want to be a little warmer for a couple of days or somewhere else. If you've got a surgery coming up, most of our members are getting an incentive for participating of somewhere between $2,000, $3,000, $4,000 that they're pocketing as part of that program as we share the savings. I can give you a quick example of that. A shoulder surgery in the Chippewa Valley is going to average about $45,000. Typically, when somebody travels to Mexico, Texas, even Pittsburgh, bless you, Pittsburgh, Texas, Mexico, Caymans, Costa Rica. We've had people go a couple other places, the Bahamas. That shoulder surgery, most of those places is going to cost us about $15,000 instead of $45,000. That $15,000 is going to pay for the surgery at a world-class facility. It's going to pay for travel for two, staying on location near it at a resort or a hotel for 7 to 10 days while you're recuperating and the doctor's checking up on you and things like that. Paying all your expenses for those 10 days, and then you're pocketing an additional $2,000 or $3,000 in the process. So it's the folks that have done it have really enjoyed it, have to the extent that you're enjoying a surgery. But I've gotten a lot of pictures of people that sometimes go down a few days early and things. Half the pictures I get have a bartender in them. I don't know why, but hey, we're in Mexico. So it's been an interesting program, and we share the savings with our members when they participate. So let's talk about not just cost but service and the service issues that we regularly experience as healthcare has changed and gotten more complex, and things like that. Preventive care visit. Who scheduled a preventive care visit lately? This is where all the hands shoot up. How long do you have to schedule it out? How far out, do you know? 2 months? What?
At least 6 months usually for mine.
Really? Okay. Typical is about 2 to 3 months, somewhere in that range. And if you're not feeling well, you want to go see your physician. Odds of getting in to see your doc are usually pretty low, right? So you're going to go into urgent care or to the ER. Hopefully, don't go to the ER. But you're going to go into urgent care. You're going to wait in line in an urgent care office. Always 3 little kids coughing on you and stuff. It's a lot of fun. Or if you've got your kid coughing on you and you got to get into urgent care, they always start at, ear infections always start at 2 o'clock in the morning, right? And then you sit And you wait. You're like, okay, we gotta leave right away because we gotta be the first in line of urgent care at 8 o'clock in the morning. Mine are a little bit bigger now, but I still remember it like it was yesterday. Or because your physician now has so many patients that they take care of, they don't have time to treat anything that you've got, so they got to send you to a specialist. Want to guess the specialty that has the longest wait times in the valley?
Dermatology.
Ha. Pretty good.
Oh, yeah.
I've done this, they're laughing because I've done this presentation more than a dozen times, and only one group got it wrong. It's dermatology, and the typical wait time for a dermatology appointment is 6 to 9 months right now, depending on what you got. And I know there are a couple of dermatologists in town that even if you know you've got to get a mole taken off, they want to get you in for a consult, make sure it has to be taken off, and then it's going to take another 2 months for them to schedule to take it off. So you're waiting 6 to 9 months to a year just to have a mole removed, which is something that a primary care doc could do for you. And 20 years ago, primary care docs did regularly. Why are they so jammed up? Part of the challenge is staffing, and it's purposeful or not. It's the amount of patients that a primary care doc is typically in charge of, typically overseeing to take care of. A decade ago, that target was 2,500 patients per doctor. And they got to that number by calculating if you saw every patient for 15 minutes twice a year, how many patients could you treat in 1 year? Full-time doctor schedule. And the answer is 2,500 patients. We have several clinics in the Chippewa Valley now that are staffed at 3,000 or 3,500 patients per doctor. So if at 2,500 you could only see patients on average twice a year for 15 minutes, where are you at with 3,500 patients? And now you can kind of get the feel for why, unless you schedule something way out, they're coming in and doing a drive-by because they don't have time to do anything else. I mean, they do 10 minutes, they handle one thing and move on. And if you need that, you know, a mole checked or a spot checked, or you have any other question or issue or something else, they've got to send you on to somebody else because they don't have time to you're broadcasting this to somebody else, aren't you? They don't have time to deal with this. They've got to send you on to someone else. That's why all of those specialties are getting clogged up too. We don't have more dermatology need than we had in the Chippewa Valley 25 years ago. We don't even have fewer dermatologists than we had in the Chippewa Valley 25 years ago. We just have them doing more lower level stuff and generating more charges in the process, because now instead of your primary care doctor taking care of it when you're in the office anyway, now you get 1 or 2 more charges to get that mole or something taken care of. So you've added cost, you've added frustration, you've added wait time, and all kinds of things like that. And it's not just dermatology. We used to have 1 part-time endocrinologist in the Chippewa Valley, and now we have several endocrinologists taking care of folks with diabetes, most of which could be managed by their primary care doc if their primary care doc had time to do that. And it's just those kinds of things. So there's a different model, and we look for different ways to, how can we accomplish that? In addition to the service, we know it's expensive. An urgent care visit is $400. If that's walking in and maybe getting an x-ray, that'll be about $400. Emergency room, anytime you go in, it's going to be $1,000 or so. Our average is $1,600, but if you look at just the simplest stuff, $1,000 to get into the emergency room. And a lot of people think emergency room is going to give you better care. That's like the best area to get care. It's actually the worst. Lowest quality care is provided in the emergency room because they're not built to do the low level stuff. They're built to deal with a car accident and stuff like that, and people coming in, that really need truly emergent kind of situations. So this is one that we get. This is the question that we get most often in our member services group. When people call in, they've got a question or a complaint. You go in for your preventive care visit, which is covered first $1, right? Don't have to worry about paying for anything. And the doctor says, "See, you got anything else you want to talk about?" You say, "My shoulder hurts, back's a little sore, can't sleep at night," something like that. Boom, you got another charge, and suddenly you're paying a copay for that visit. And people call up and say, "Hey, why do I have a copay?" Or if you have a deductible, why am I paying for that additional charge on what I thought was a preventive care visit that'll be fully covered? Because once you say, "Yeah, I got something else going on," it's not a preventive visit anymore, and according to the billing rules and everything else of the industry, they can charge you for that. So now that visit that was $3,000-$4,000, $300-$400 to $1,000 depending on the labs, now you've added another $200 or $300-$400 charge on top of it. talk about labs, because labs are a key part of our costs. Labs are very expensive in the Chippewa Valley, and they get marked up a fair amount. I'll talk about that in a little bit, just how much. But if you go in for a primary care, just a preventive care visit, somebody my age, let's say young, anybody laughs, they're dead, and they say, let's do a cholesterol check. You say you're tired all the time, so we'll do a thyroid check just to make sure it's not your thyroid. You could actually sleep once in a while and you'd be better off. And we're going to do a comprehensive blood panel because we haven't done one of those in a while. Those 3 tests. Depending on where you go in the Chippewa Valley, that's going to be somewhere between $750 and $1,000 just for those. Wait till you hear what they're actually costing them. Imaging, if they need to do a CT or an MRI, while we've negotiated some reference pricing and some lower pricing around the valley, you're going to be minimum $1,000, $1,300 somewhere in there, or $3,000 for an MRI. And those both, depending on where they're doing it, if they're doing a head and neck CT with contrast or something like that, you're in the $4,000, $5,000, $6,000 range pretty easily. So things get very expensive very quickly. So we look at it, we say, let's look for a different model. What if you had a doctor that had time to treat you, could see you same day, next day if you had an urgent care situation, instead of a 20-minute or 30-minute preventive care visit, took 45 minutes to an hour for that preventive care visit. Anytime you come in, you can talk and work through all the issues you have, not just more of the most important issue or the 2 most important issues and things like that. And they actually took care of all those things. There is a model that's kind of been spreading throughout the country called direct primary care that kind of provides a solution for us that does these things, lowers the cost because it focuses on primary care, really the way primary care used to be delivered, with doctors that have more time to actually take care of the patients that they take care of. It grew out of a different kind of demand and a different kind of need. And it was coming on both sides. We'll start from the consumer side first. As costs were going up, especially after the Affordable Care Act was passed and the individual and small group policies had mandated benefits that were increasing the costs and things like that, deductibles over the last 10 years have gone very high. A high deductible 10 years ago used to be $1,500 to $2,000. Now, in the individual market, a $10,000 deductible is not uncommon, and I know folks who are paying $20,000 family deductibles in individual policy. Small group policies, not quite as high, but getting up in the $7,500, $8,000, $9,000 range for a family deductible. Let's face it, if you're at a $10,000 or a $20,000 family deductible, you're talking about catastrophic coverage. You know, I mean, because the only way you're going to get there is if you've probably got, a surgery or something like that, hospital admission, and who can afford to pay that? I mean, most folks can't afford to pay that kind of thing. So rather than participate in the system at all, they found doctors who would take cash and charge them, X dollars per visit or X dollars per month to take care of everything they could take care of. And it turns out a primary care doc that has the time to do it can take care of most of your healthcare needs, and dramatically reducing the amount of need for a trip to the specialist and things like that. Doctors, by doing this and freeing up their time and kind of reducing their administrative overhead, they're not filing insurance claims and things like that, they have the ability to treat fewer patients much more efficiently. And so because they're taking care of 800 to 1,000 instead of 2,500 to 3,500 patients, they do have the time and they can make it work. And they can do it same day, next day and things like that. So it actually is care when you need it and where you need it with a doctor that knows you. And because they know you and you don't have to explain it all over again to every doc that you see, it's a much more efficient process. On the flip side, the doctors, why would doctors do this? Well, you can imagine that for somebody that went into healthcare to take care of people, the idea of coming in, sitting there for 10 minutes saying, okay, blood pressure is this, you gotta go, bye. And they move on. That's not a terribly rewarding process for them. They get burned out, and primary care docs especially have gone from being one of the highest satisfaction levels among professionals to one of the lowest. And they've gone from one of the lowest suicide rates among professionals to the highest suicide rate among professionals. So they're burning out like crazy, and doctors are saying, I'm out. I don't want to work for one of the big systems anymore. I'm going to go just hang up a shingle and charge cash and see what happens. And it turns out that there is a fair market for this. Around the country, clinics are popping up everywhere. There's hundreds of, it's more than hundreds, of primary care, direct primary care clinics in, the first time I was giving one of these, I almost said in every state, but I realized North Dakota doesn't have any. So the 250 people that live in North Dakota don't have direct primary care. Everybody else does. And so we've looked at this for a number of years and talked to different kind of players and things like that, and looked at, one, how could we get somebody to help us build a clinic and staff the clinic, because we didn't want to do it, and find somebody that's got experience at doing this and that can put it all together for us and create this independent doctor, independent of all the other systems, that's there for the patient. And and people really feel like the doctor is there to treat them and not kind of answer to some other need and meet a volume target or something like that. We looked at several different organizations that are helping build the clinics around the country, establish the clinics, I should say. And we quickly kind of focused earlier this year, it's still this year, on Solidaritas, which is a group that's opened several of these clinics around the country, and very similar kind of cultural perspective, very patient-oriented kind of idea and manner in which they put things together. We quickly put a model together, came to agreement in a great way. They started recruiting. In the process, found Dr. Jody Rich. She'll give you her story in about 5 minutes. Don't hold me to that, but I should be close. And they're recruiting for a second doc right now. We're planning on opening up a clinic. They are planning on opening the clinic January 2nd. The clinic that they will have long-term is being built out in River Prairie. It's in the same building as ZA 51. So kind of right in the center of the kind of metro area in terms of drive times and things like that. It's a very convenient location. Before that is ready in March sometime or early April. They'll be using Dr. Rich's current clinic over on Brackett Avenue, right across the street from Culver's. Is it right across the street from Culver's?
It's
It's kind of across the street from Taco Bell or Taco John's, or still one
kitty
over.
corner.
Okay,
There's a coffee shop across the street.
it's just this way.
If you lived here long ago, then the Taco John's was across the street. But the Taco John's upgraded a few years ago and moved a block over.
It was more than a few years ago.
Back in the day.
Yeah, because I don't remember it ever being on the other side of the street.
That was before your time. I've been here since '71.
Really? Well, maybe I just didn't pay attention. When did they build this Taco John's? I love these conversations. This is always good. When did they build this Taco John's, the ones there?
Yes.
I remember what the old ones used to look like, but I don't.
Apparently,
A long, long time ago, Pete.
A long time while Claire's been president over here.
Yeah, since
Used to be the windmill drive-in there across the street from me.
Oh, wow. Wow.
Jim remembers. I don't eat junk food, so quiet down. Sarah's here, so I don't eat junk food. Never been to Taco John's. Where is that? What? I've heard there's a Culver's. Sorry, I got distracted. I was thinking custard for a moment, and I'm a Milwaukee boy by heart, so custard. Culver's isn't even the best custard. You got to go to Milwaukee, one of the stands there, to get really good custard, right, Fev? So who's your favorite one?
I live closest to Cops. So.
When you're in Milwaukee, did you have a favorite? Oh, Cops. Yeah, Cops.
But I never went.
Gillies. Gillies custard on Blue Mound.
Yeah.
These can be long debates about who has the best custard. Okay, enough of that. So we're adding a benefit plan to the benefit that you guys all have right now, an option for you. And to enroll in a plan that has the Solidaritas Clinic as your primary care clinic. All the rest of the network is the same. You have the same access to all the other doctors that you have access to right now. The fundamental difference between the two is anything you have done at the Solidaritas Clinic, will be no charge. Any number of urgent care visits, other primary care visits, anything that's done there, any procedures or anything else, all no charge. And Dr. Rich is going to kind of walk you through the scope of what that means in a minute. Okay. Everywhere else, you're going to have a copay. So this says specialty visits 100% at the DPC, meaning any of that care that you thought a specialist normally would do, like dermatology or something like that. If they do it at the direct primary care clinic, then it's no charge. Otherwise, you have your copay for any other physician. If you get preventive care anywhere else under this plan, you'll pay that also. You'll pay that $30 copay. Is it a $30 copay? Right? Okay. Urgent care. If you go to an urgent care clinic, you're going to have that same urgent care copay that you have now. If you get that done through your direct primary care doc, you won't pay anything. And the emergency room copay goes up just a little bit. So it's easy to kind of overthink this, but because it's insurance and people think, all right, there's a catch here somewhere, this is complicated. Just think of it as everything you have now, pretty much the same, but if you go into this other plan, it's everything you have now and the Solidarity's clinic, and anything you have done at the Solidarity's clinic is no charge. And then you have the same kind of stuff you have now, and we've got the charts that kind of walk you through all of that. A couple of things in the services, and I just want to talk about this before Dr. Rich gets up. So they can do all the things that your primary care clinic can do right now, for the most part. They're drawing labs there. They're using LabCorp, which is one of the 2 national reference labs. Several of the other clinics, even the larger systems, farm out some of their labs to either Quest or LabCorp. So it's not unusual. They've got an arrangement worked out with LabCorp for kind of a bulk agreement and some fairly low rates. And our contract with them, they're passing those through to us at cost. So this is one of the ways that we're really saving a lot of money. So let's talk about that example of a preventive care visit where you go in, you have a comprehensive blood panel done, a thyroid check, and a comprehensive cholesterol check. So you get your LDL, HDL, and triglycerides. And that's going to cost, if you go to one big clinic in town, it'll be about $750. If you go to the other big clinic in town, it'll be about $1,000. You want to guess what all 3 of those combined are going to cost us if you have that blood drawn at the Solidarity's clinic?
$50.
It's a good guess. $50. Thought you were going low on that too, didn't you? Yeah. Anybody else want to take a guess?
Probably $250.
That's, I mean, right? Because then you look at $250, then they're kind of marking it up, 3 times over that. That'd be pretty good. How about less than $20 total? Right? So they sent me the list a couple months ago when we were working out. Their CFO sent the list over. Here's the list of the labs we do, and the price of the most common 50 labs. And I'm looking at it, so I look these up, right? And the thyroid check was $1.98. The cholesterol check, well, one of the 2. One of them was $4.98 and the other was $1.98. I mix them up. And the comprehensive blood panel was like $8 or something. I don't remember. Do you remember? It was something like $8. So it's the 3 of them under $20. I sent him a note back. I said, you sent me the wrong list. I don't know what this is. Just making sure you want to send me the right one. He sends it back and says, I know, that's the list. That's actually it. Less than $20 for something that right now we're paying $1,000 for. That just gives you an idea of the markups that we're dealing with. And like I said, there are clinics in town using the exact same provider. So, I mean, it's not like this is a kind of low quality provider or something like that. It's one of 2 national programs that a lot of clinics use. So we'll save money there. We'll save money on kind of a less need for diagnostic tests and things like that, because a lot of times what they're doing is just kind of placating a patient, moving them on and say, yeah, let's just go see what we can get, rather than sit down and work through it, really talk through the history and getting a good comprehensive history with the patient. Okay, I've talked about Teladoc, I've talked about destination medicine a little bit. The only plug I'll give you beyond that for destination medicine is if you've got any kind of procedure coming up, anything at all, give us a call, give Best in Class Care a call, And let's see if we can work out. And I just like leaving this screen up for a while. If you pretend that's white sand out there, it really looks just about the same. And to give you one example, this is a case that we just had recently. We had an individual who's being treated for a recurrence of Hodgkin's lymphoma, and they've gone through their chemotherapy treatment, and the course of care after that is infusions of a drug like Remicade, one of the biologics, every 3 weeks for a year. Every 3 weeks for a year, they got to get an infusion done. The cost of the drug, like wholesale cost of the drug, if you could buy it at a pharmacy, would be $24,000. You want to know what we're getting charged here by one of our large clinic systems? Mary knows. You can't answer this. Okay, and neither can you. And Alyssa and Michelle know too, so you guys have to. $24,000 cost of the drug. What were we getting billed to have it infused? Who said 60? Did you say 60 grand?
Yeah.
$62,000. 62, nicely done. I should like give you a pen or something. We'll bring pens. Oh, you want a group health pen? No, I don't want a group health. Because then it's gonna be one of those pens, they click it 3 times and the top goes flying off or something. Like, you give me a cheap pen. $62,000. So we call around and we ask any of the providers in the network if they, if anybody did this type of infusion somewhere else. And we found a few places, and we talked to the individual. They were kind of half interested, and they found a place in Tijuana, Mexico, which doesn't sound like the first place you'd think if you're thinking quality healthcare. But as it turns out, a lot of people in the Southwest go to Tijuana for a lot of dental care and a lot of other health care because it's cheap. And there is a lane in the immigration at the border for just health care. And you stay in San Diego and you get on a bus, they run you down there, they treat you and bring you back that same day. And so we're talking to this individual, and he's, he kind of asked, well, what's the incentive to go? And we said, how about $4,000 a trip? He's like, well, for $4,000 a trip every 3 weeks, yeah, I'll go. Why not? And his employer was okay with it, and so we set it up. He's gone 3 times now, right? 3 times. Loves it. Says it all goes pretty smoothly. We talked to his doctor beforehand. His doctor said it was okay for him to go. The oncologist that's treating him, he said, sure, you can go. I don't care. He didn't have any concerns with it. And so $62,000 here. It costs us there $27,000, that sound about right? $27,000, and out of that $27,000 he gets 4. Yeah, so he's pocketing $50,000 through the course of the year. We save almost $500,000, and that's about the ratio we try to do. We try to, share about 10% of the savings with our members and things like that. He's happy. He's taking different people with him and stuff like that. Different family members get to go to San Diego and Tijuana. I wonder if they're getting tattoos while he's getting, I don't know. Because I think that's the only people I've ever known, go to Tijuana end up coming home with a tattoo. Okay, I'm done. I'm gonna turn this over to Dr. Jody Rich. Some of you may know her. She's been in the Valley for a while practicing medicine. But you can give your whole background, how you ended up here today.
You bet. All right. Thanks, everybody, for coming in. So like Pete said, oh, thanks. Oh, good. Okay. January 2nd. I'll see you that morning. So I'm Jody Rich. I grew up here in the Chippewa Valley. That's why I know all about the Taco John's. And I left for undergrad and med school, and came back for family practice residency. And then, so during the residency, that's your kind of on-the-job training. I worked with all the systems then, and then I ended up joining Mayo Clinic. And I worked there for 15 and a half years. 11 of those years, part of my family medicine practice was to deliver babies. So I had a lot of families that I saw through their pregnancies and then their well child visits, and so a lot of kind of longitudinal care. So a lot of visits over time. And so I had a big group of people that I know their families really well. And so when I gave up delivering babies, because I figured out that I needed to sleep through the night too. When I turned 40, I gave up delivering babies, and I pretty soon after that got very burned out because all of a sudden, all my kind of longitudinal families were kind of out of the picture, and I was just seeing people for these very brief visits like Pete was discussing, and having to just kind of be frazzled because I knew that when they came in, they were saying, oh, I would have wanted to see you, but I had to go to urgent care because I couldn't get into you for 3 months. So here's my list that I've been creating over the last 3 months, and what can we do about it? And of course, we have the EMR and things to deal with, and so it's a very short period of time, and so it was just very dissatisfying to have these short snippets, maybe once or twice a year, and then not seeing people the rest of the time. And so I told my husband in 2013, I'm either going to go work for the Micon and watch a lot of movies, or I'm going to start my own clinic. So I left and started a cash clinic. When you leave a big system, you got to go 25 miles for 2 years away from where you worked. So I went to Menominee, and that was lovely. I had a small clinic there, and then when my non-compete was done, I moved back to Eau Claire and had both for a while because I thought maybe I could clone myself or find somebody else, and then eventually consolidated into Eau Claire. But during that time frame, I did do a semester little help out at UW Stout, and they were shorthanded, and so to be in student health and to be able to see people back just with no extra copay or any money involved was really refreshing because I've been, working for cash or chickens or whatever I was working for prior to that. And so to be able to say, wow, you really, and of course the students, they're all homesick and they're feeling lousy. They got mono, they got strep and things like that. And so to be able to say, well, why don't you just come back tomorrow and we'll see how much better you are, or why don't you come back in 3 days or something like that. And so this idea of direct primary care got to be something I was interested in. So when I moved back to Eau Claire, that was part of what I opened, was this direct primary care clinic. So now I've had that going on for almost 3 years. It'll be 3 years in March. And it's really been a great benefit to me as well as the patients, because it's really my group of people that I get to know well. And so I really wasn't looking for any sort of change. I kind of figured I'd, keep this practice going until I retired someday. And I got approached by the recruiter for Solidaris Health this summer, and she said, you should find out more about this. And I said, well, maybe, I don't know. Not really interested, but and so she started talking to me, and when I kind of heard the whole idea, it seemed like a lot different than what I had kind of heard before. So and really the ultimate is this idea that spending more time with people is what is the important part. So 50 years ago, you had a family doc, and they knew your whole family, and you called them when you had a problem, and it was kind of the Marcus Welby, if you remember who that is, or Dr. Quinn, Medicine Woman, I don't know, Northern Exposure, whatever your genre is, not Grey's Anatomy. But I think that, it's kind of a pendulum swing, because things have gotten so crazy in the big systems as far as like cranking people through. I mean, I worked in a big system, and I know that when I saw people, I was like, listen, I got 2 people in other rooms waiting for me. What do we need to do today? And we'll have you come back in a month. And that became 3 months. And it was just a totally different system. And so when I moved out and I opened my own clinic, and of course you're very slow in the beginning, I thought, wow, all these people that I thought were so hard, if you just spend more time with them, they're not really that hard. We just got to get to kind of the bottom of things. So that's really what Solidaris Health is about. And so that's why I decided to join them and close my clinic, because it's a way for me my ultimate goals were to be able to have a sustainable model where more providers could escape the systems and more patients could be served and more time could be spent one-on-one. And so I decided to close my clinic because I believe in the process so much, and that Solidaris can take it to the next level here in the Chippewa Valley, where we have very expensive health care, and the providers aren't happy and the patients aren't happy. And so if you are happy with your primary doc, then that's great, and just pay the $30 copay and go see them. But if you can't get into them, then come see me and whoever else we're going to hire, because I think you'll have a different experience. And it's kind of hard. I always tell the anecdote that when I was starting my DPC, I told my sister about it. I said, oh, it's going to be great. They're going to pay a monthly fee, and then they'll be able to text me pictures, and they'll be able to have video chat conferences. I won't have to have them come in for every little thing. And she was like, I just don't get it. I don't really understand. And I said, well, yeah, that's because your sister's a doctor, and if you get a tick, you send me the picture. So I always kind of tell people that it's like you're, have a family member who's a doctor that you can kind of reach out to and to get some answers. And, the problem these days is a lot different than 50 years ago. 50 years ago, you had to go to the doctor to get some sort of information, and now we have Dr. Google. And so the information is so crazy, you need somebody to help you kind of sort through it all and see what am I, really worried about here, and what can I be, let go that's just not really in the realm of possibilities. So it's a totally different perspective, but still, I think the best way is to have time to talk about it and talk about the things that are bothering you, and also to address things from a staying healthy perspective and not just like putting out fires when they come up. So I think that covers most of it.
You get to know your patients, so some of the simple things you can handle by phone instead of, or a video chat or a picture or something like that, rather than having to come into the office.
Yeah, actually today's a great example. So I was sitting in my office and I was between patients, and somebody sent an email like, hey, I just was wondering, like, what do we use for video chat? Because I got this armpit rash, and she lives in New Auburn, and I know her well, and I said, well, why don't you just shoot me a picture? And so she sent me a couple pictures of her armpit, and I told her what to do. We talked about a few things, and it was done, a couple minutes. So she didn't have to like go to the store and try 6 things while she waited for that appointment. And if it was something that she needed a biopsy of, we would do that. We freeze warts, we take moles off. I don't take things off the face because it's your face. So that's one thing that people come in and they're like, can you take this off? I'm like, no, I'm not going to take that off because it's your face. But if that same thing is
She
here.
can't take this off?
Yes. Just trim it a little. No, I don't mean to do everything. And I'm certainly not going to be, a gatekeeper telling people they can't go see specialists or something, because there's definitely times you want to see a specialist. But if it's something we can do in the meantime while you wait, and then maybe you can cancel that appointment, then that's great too. It saves everybody a hassle. So, depression, anxiety, high blood pressure, diabetes, reflux, gut issues in general. Those are like all bread and butter stuff, things we see all the time. Warts, acne, I don't know. There's a lot on the list, but those are, I would say, the majority of things. And then, of course, people's annual physical and just wellness type stuff. And there is also, I don't know, you didn't mention the medications.
I did not.
So medications are part of Solidarity's Health as well. So for instance, there's probably about 7 high blood pressure medicines. So if you're on one of those generic high blood pressure medicines, you could get it dispensed right from the clinic, and you wouldn't have to go to the pharmacy.
So they'll stock 50 or so of the more common prescriptions, and they actually look at the utilization of the groups that they're taking care of. They'll stock the 50 more common prescriptions, so they'll be able to dispense those from the clinic at no charge, rather than you have to go to a pharmacy or something like that. And they keep those on hand.
I saw a lady today who had a bad sinus infection. She's been sick for 4 weeks, and I was like, sorry, you gotta.
Wait to get the drugs?
There's not. There's a 3-minute wait. I just say, here's the amoxicillin, and call me if it doesn't work or come back. So so she was like, oh, it's okay, I'll go to the pharmacy again. But things like eye drops if you have pink eye, or cream if you have a rash, or things that are quick that you'd want to get taken care of.
But that's a good question. The scheduling is kind of a real fundamental part of it, in that there is technically a waiting room, but it's just a few chairs in the model, and the way it's set up. Because when you call your doctor, and you're calling your doctor, well, you've got her phone number, their phone number. You can call them at night. In the middle of the night, I'm assuming it goes to a service. and then sends it over to you. But you get to talk to your doctor in the middle of the night. So if your kid has that ear infection, and you know it's an ear infection, and it's like my first son. Second one wasn't so bad. First one had an ear infection, I think 2 a week. And the only challenge we had was figuring out if the little pink bottle of, is it still pink? Is it still that bubblegum flavored amoxicillin that just gets sticky and sits in the fridge and it's like, oh, if there was a fresh one or not. Because we had one in the fridge all the time. And so if you got to call in, you can call in the doctor. They can give you the prescription right away or something like that, or and rather than have to go under urgent care and things like that. So, and then if you do have to go in, they'll tell you what time to come in, so they schedule it for you. And instead of rushing off to urgent care right early in the morning, you got to get there in line, otherwise you're going to wait for an hour. And so it's come in at 9:15 or 10:45, and so you can plan the rest of your day, and you're going to get in at that time because they can schedule it in the way that they've got the patients coming in and the blocked off for urgent care during every day, right? You can get in and not have to say, okay, this is going to take me 1 to 2 or 3 hours, depending on if it's cold and flu season or not, or something like that. Or what are the worst urgent care days? Is it Monday or Friday? Monday? Is Monday like a terrible urgent care day? I don't even remember.
Depends on if they're closed on Sunday.
Yeah, right. Exactly. So they're all just like sitting at the door. And so you've got that, the ability, because your doctor, take care of a lot of things on the phone that otherwise you'd have to go in on. If you're traveling and you need a prescription or something like that, if they've already met you once, they can prescribe if you're out of town. And so that's a great reason to establish the relationship.
Yeah, that comes up if people forget their medication, or they always get a bladder infection when they're in Mexico or something like that. Well, Mexico's a bad example.
Right.
Florida. Although technically in Mexico you can buy whatever.
Right, it's easier to get.
But yes, that is really handy. I have one patient who's used that a lot. She's always like, I'm just leaving on a plane tomorrow, and this is what's going on. Anybody else have any specific questions?
So yeah, what kind of questions do you have? It's possible after 13 or 14 of these presentations, we've skipped over a couple of things.
Yeah.
What are your hours?
Well, 10 to 6 or 7 to 3, depending. So 10 to 6 on 3 days a week, 7 to 3 on 2 days a week. So I think Tuesday and Friday are the 7 to 3, and 10 to 6 on the others.
But sometimes that might be flexible. You can call after hours, so you can call them anytime.
Right, that would be what's available online scheduling. So, yeah.
Right.
Yeah.
The clinic does have a member portal, a patient portal, so that you can get lab results through the patient portal. They've got a really cool online portal, so you can do that, and you kind of get that background, and all your medical records and things like that through the patient. Well, not all of the comprehensive, but your lab results and stuff like that. So, question over there.
I was on the first question here about the urgent care option. So it's a weekend, and your first call should be to you, or to the clinic.
Yes.
And then you'll say, oh, we have proof that you should be seen at an urgent care facility,
Potentially.
potentially.
Yeah. What would?
You need to go to the ER right now.
Yeah, but it's like,
Yeah.
yeah, but
If a bone is sticking out, don't bother calling. Just go ahead and go to the ER. That's right. Yeah. Right.
I'm not gonna non-threatening.
Yeah.
See, I don't know,
Like in the summer, a tick bite comes up a lot on the weekends. And so, for instance, if you called me on a Saturday and you said, I got this tick bite, I just had Lyme's last month and stuff, I'd probably say, well, you want to do a virtual visit right now, or do you want to just send me a picture? Or, we kind of talk about it over the phone, but we decide whether or not it'd be something that you need to be seen that day.
I skipped over one thing that should have been in here, and somehow I deleted it in the presentation. So, specialist visit. Normally you have a $30 copay with your specialist visit. If you've gone to see your direct primary care doc and they agree that you need to see a specialist, that copay goes from $30 to $10. So it's not you got to go see this specialist. We're not going to steer you towards somebody. It's if you need to see, like an orthopedic doc, you've got something that is beyond what they can handle. And they say, yeah, you got to go see an orthopedic doc. Or, I had somebody with MS ask me this question. Certainly somebody that's being treated for MS is going to see a neurologist, right? Okay, good. And just every now and then I throw out the wrong one. Going to go see a neurologist. So for those folks with a chronic condition that needs to see a specialist, your copays will drop. But it's still important to have that relationship with a primary care doc so they get to know everything else that's going on and can then take care of you kind of for anything else that pops up and all those other things. So it's not, as Dr. Rich said, not a gatekeeper kind of scenario, but more just an encouragement to establish that relationship with your primary care doctor. But so all of the things that we've structured are ways to reduce your cost, lower your cost exposure, and find ways to kind of provide it more efficiently and share in the savings so that you're getting a chunk of those savings as we move forward.
Is there a big trend going this way, or is it just kind of new? I mean, yeah, there's a lot of clinics, but obviously the hospitals are all big.
Yeah, it's interesting. On the self-funded side, large employers are doing this a lot and moving towards it to try and kind of cut out those overhead costs. And on the individual market, a lot of people are using this. We're the first insurance company that I know of in the country that's doing it on an insured group basis. There's one putting together an individual plan down in the Southwest that I just found out about a few weeks ago, but I think it's going to grow. Now, we also, it does, right? And it upends the revenue model of the large systems because, they treat primary care as kind of feeders for the rest of it. And we have an expensive area. This is an expensive part of the country, so it makes sense that this would be one of the first areas where it would really work.
It's
And why not?
I'm going back to basics because
Right.
you're right. If they pawn you off, you got to go here, you got to go here, and that's why my wife never goes to the doctor. She just refuses because she's not going to go wait for 6 months for something. So she's very enticed by a program like this, but I could see it becoming a bigger trend because of that. But it's
Right.
ripple effect to every other profession because nobody's running it. So
And it actually puts the patient in charge of a lot of things. You're right in the decision-making process, and you can go see a doctor when you need to see a doctor.
Yeah.
Yeah.
We're doing it because we're smaller.
And that's a good point that I've skipped over. A large insurance company wouldn't be able to do this. We've got to, in order to keep the overhead low and their costs low, there aren't a lot of claims flying back and forth between their clinic and our office and things like that. A large insurance company that's, or statewide or running a number of states or things like that wouldn't be able to make this work because they'd have to fit it in their processes. And we have, and one of the ways we're able to do this is Solidaritas can work together to kind of get us the data we need to have and yet keep everything as administratively streamlined as possible so that there isn't a lot of overhead involved and things like that. Having them a mile away, or a mile and a half away so that we can stay in close contact and things like that. So for example, the referrals, we'll get the list regularly of who, the doc says need to go see a specialist and what kind of specialist. We're not going to care about which doctor. Anybody in the network is fine. So if you need to see a neurologist, you pick a neurologist that you either have a relationship with now or they can help you find one, and that's good enough for us. In like an orthopedic doc or something like that, we're not steering anybody with this process. We're just saying have that relationship with your primary care doctor, and then your copays all come down. So all else being equal, it's the same as what you've had before. Same structure, but if you choose to enroll in this plan, then you've got the option to lower your costs even more. And the premium's a little bit lower. I don't remember. It's down a bit, a couple points lower, right?
They all have, I think, the sheet. Oh, they don't have that.
Okay, we'll get it. Right. But it's a couple points lower, I think, right? So, any other questions that we can answer for you?
Pete?
Yeah.
Can you repeat the questions and then answer them?
Sure. Okay, everybody that asked a question, you have to ask it again. Take two. Cut.
So, as far as previous medical information, how much of that do you prefer from your patients? As you're going to have a lot of new ones.
Right. you know, typically we just have people sign a release of information when they come in. I mean, those of you who have a binder and you have your stuff all organized, that's fantastic. I love that. But if you don't have that, then we can easily, you know, sign and send for your records from somewhere else. So, I mean, typically they send the last 3 years. And so unless there was something real pertinent 10 years ago or something that we'd need special requests for. But most of the important stuff, if you've been seeing someone fairly regularly, would be in the last 3 years. And usually anytime you go in for a physical, they're kind of summarizing what's happened prior. And so so that's a great example. But I encourage everybody, just in this day and age, and you know, people are flying all over the country and stuff, you know, just kind of put a little list together and have your own information with you, because
But
just
medical
makes it
records
easier.
do move around between that's a good question, Sarah. Between the clinics a lot, there's kind of this myth that either one, there's a real coordination within a clinic system because they don't share as much information as you think they would. And that nobody goes to other systems. And I mean, you know, for example, Mayo Clinic thinks all their primary care patients see nothing but Mayo Clinic specialists, and Marshfield Clinic thinks the same thing. They all think it. And I've talked to other systems around the country, they all think that. And as it turns out, it's pretty constant around the country that 20% to 25% of their patients go somewhere else also. So they might, you know, have primary care in one system and go see a specialist in the other one, either for access or somebody said this is a great doctor or whatnot. So they're moving around a lot and trading that information. We're moving records. Sometimes at a clinic here or there, once in a while, it can kind of log jam, and we got to kind of kick it through a little bit to make sure the records get transferred and stuff. But usually that's not an issue. But it's a good question because depending on how much history you have that's relevant.
Right. A lot of people have access to a portal, you know, so I just have people bring it up on their phone if they know what their portal is, and we just look through it quick that way. And so it's, I mean, there's a lot of great technology available and a lot of great ways to connect, so it doesn't always happen just the way we want it to, but it hasn't really been a problem. And I've been, you know, 6.5 years now outside a big system, and I've never really had a problem getting the records that we need. So.
Family practice docs, so you can treat the whole family.
Yeah, so the Solidaris model is to have 2 MDs and 4 support staff in one location. If we get to the point where we need the 3rd and the 4th, there'll be a 2nd location. So it's never going to be like 16 doctors in one area where you're coming to a big place. It's always going to be small little places. So, which is really helpful,
right.
I think.
And I know they're close on a 2nd doctor, but if the 2nd doctor isn't available right at the beginning of the year, what we will do is allow folks to wait and switch when the new doctor comes also. So we'll have another kind of open enrollment period whenever that doctor is going to be on site, and so we can expand that. And then, and we have committed to, I mean, the reason we're offering it to just 3 groups is the total of those 3 groups is less than their capacity for the 2 doctors at that clinic. And so depending on how many folks sign on, then we kind of go through the math and figure out and start a 2nd clinic with 2 more docs somewhere else, and we work that out with Solidaris, and then we can start offering it to other groups and kind of bringing things up to speed. But even if everybody signed on in all 3 groups that we've offered it to, you guys, the city, and us, they'd still have the capacity to treat everybody. So that's kind of how we decided who would do it, and we asked Mary if you guys would be one of the first groups that we would offer to, and Mary said, yep. So Jim said yep.
I'm really excited about this.
I am too, honestly, and it's something that we've been working on for quite some time, and I've used I learned not to use the Marcus Welby analogy because people like Alyssa stare at me and say, who the heck is Marcus Welby? But at least half of our employees now, when I said, it's like Marcus Welby, looked at me and said, who's Marcus Welby? But
I was getting videotaped by Andrew.
He's the best doctor in the world.
Andrew
50 years ago.
videotaped me, and I was like, so I'm only going to have 800 to 1,000. You should join my team. And I felt like I need the voice chair. Just turn around. Please be on my team. I'll give you a T-shirt. So that's a modern reference, The Voice.
Right?
Have you seen it?
Yeah. I work a lot. Yeah.
Okay, so I've got my primary doctor, so instead, if I enroll in this, I would go to you before I would ever?
Or how does that, I'm just kind of curious.
Yeah.
In a,
I mean,
in a perfect world,
sure.
instead of.
Yeah.
So you'd switch. Totally switch.
But
Now here's how this works. So let me walk you through because but it's voluntary, right? Because even if you enroll in this and you stay with your doctor now, you just pay the copay. Okay, so that's the only difference. And what a lot of people do, especially, let's say you got a family of 4, right? You got 2 parents and 2 kids, and the odds of everybody saying, "Yeah, let's all go right away," is pretty low. So this whole process is structured to not add cost if you don't do it, but to reduce your cost if you do it. And the idea being that through word of mouth, as you hear other people do it, or as one person in the family tries it and says, "Wow, this actually worked pretty cool. I could actually call and get in that day, and for something I needed to, or early next week for a preventive care visit or something like that when I have time, and kind of work through stuff." And they actually take time and they actually listen to us. If you, what they found and Dr. Susanna Gale is the Chief Medical Officer for Solidaritas, is a practicing DPC doc down in the Delafield area. What she said, especially with kids, a lot of people do is they use them for urgent care. Rather than having to go into the urgent care clinic, sit and get coughed down by somebody else's kid and your kid, call, go in, get taken care of right away, you're done. And so you can just use them for urgent care. And a lot of people kind of test drive it with urgent care. And then eventually you realize, gee, well, you got them in for urgent care. We can do another visit. We can do the preventive care stuff, blah, 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 get it out of the way. And suddenly you're seeing them as your doctor.
But there's no reason that you couldn't see both either. I mean, I have a lot of patients that will go for their physical, but they won't mention their depression or whatever because they don't want to get that second kind of. A lot of my chart people right now have really high deductibles, and so they're not trying to trigger the deductible. So, but there's no reason you couldn't get a second opinion too, or just get your, come for a visit, maybe get your labs there. If any of the meds are on the thing, use it to your advantage, I would say. It's one of those things where I feel like until you experience it, you can't really understand it. Like if I always stayed at, the Holiday Inn Express and I never went to the Ritz-Carlton or something like that, it would be hard for me to kind of know what the difference between those things are. So service is one of Solidaritas' big things. I mean, they just want, as a company, to have great service for all the people that are involved. And so I have worked in a small place, I've worked in a big place, and I know what the differences are. And for some people, it doesn't matter. Some people, they love their provider and they're willing to wait, and that is great. But there's a lot of people that don't go in because of the hassles. And so we're trying to remove all those hassles and make it more of a great experience. So, any other questions?
I think that question that you asked, Cheryl, was probably the one question that I had gotten from people before we started was, if I'm seeing some sort of and this was primary care, but a specialist now, and I'm not done with whatever's being treated, how do I stay there? How do can I stay there and switch over to, in this case, Solidaritas? And the answer is
absolutely, yeah. Yeah, you should definitely try it out and see. And I mean, there's not, the way the plan's structured, there's not really a financial disadvantage other than that one $30 copay for your preventative visit with your regular provider. That's really the only difference. So it's a $30 gamble. And I think you guys are, to have this, like my personal patients, are going to pay $81 a month if they want to come with me. And so for you guys to get that benefit just thrown in, just for the good of the whole, I think is really a great advantage and an awesome opportunity. So I hope you give it a try. But if you don't, you can sign up later when everybody else tells you about it. But you might miss my team. We might get t-shirts. I don't know. I definitely am going to have a dance party. So. Any other questions?
If you do come up with another question along the way, feel free to kind of shoot over to you guys or call our member services line. They might not be able to answer it right away. It might be Solidarity's question instead of our question. So we might have to call you back, but we certainly will. We'll get back to you and kind of work through whatever we can. But feel free to call.
And there's also reps here on Thursday, correct? Thursday.
Right.
With the whole benefit, with all the benefits, and you could ask them those questions.
But we don't know the cost yet, the premium?
Yep, I'll get that out to you guys tomorrow. So. Yeah, so in general, so we did, like Pete mentioned, the healthcare costs have risen. We have been really fortunate to have either low or no increases for many years, and I think those of you who've been here can attest to that. With our current plan, we did see an increase this year, so it's a 3% increase. With this plan, with the DPP plan, it will be a flat. There won't be an increase if you choose to go to DPC. To answer your question, Casey, if you go to DPC, we're just going to still fully fund the single plan. If you stay on the current plan, then that 3% is something you really eligible for, which is $4 a week. So it's not like a huge change, but just like a free one. Yes, I don't want to pay. We'll see you in January.
All right. That's it. That's right. I got January 2nd, January 3rd.
We're encouraging you to do as well. But going back to full, I don't have all of the two-member, full family, single, employee contributions right off the top of my head, but I'll get that out to you tomorrow.
And you'll get a t-shirt.
I gotta start designing the t-shirt. It's gonna be great.
Thanks a lot, guys. Appreciate your time.